This lecture is concerned mainly with the effects of drug on cholinergic transmission. These neurons include all somatic motor neurons, all preganglionic autonomic neurons, both sympathetic and parasympathetic, all postganglionic parasympathetic neurons, a few postganglionic sympathetic neurons, for example, those innervating sweat glands. I should mention that pharmacology of cholinergic drugs described here also applies to the cholinergic neuron lying entirely within the central nervous system. Cholinergic neurons synthesize, store, and release acetylcholine as their transmission. At nerve terminal, acetylcholine is synthesized from acetyl-CoA plus choline by an enzyme called choline acetyltransferase. This acetylcholine is taken up into the vesicle and stored as concentrated solution. When action potential invade terminal axons, depolarization of nerve terminal results in activation of voltage-gated calcium channels. The influx of the calcium triggers migration of vesicles to the cell surface and release of acetylcholine by exocytosis. Acetylcholine in the synaptic cleft reversibly form complexes with the cholineceptors. The enzyme acetylcholinesterase in the synaptic cleft quickly hydrolyze acetylcholine to form choline and acetic acid. Choline is taken up actively by the neuron and is used for further synthesis of acetylcholine. Drugs that act on cholinergic axons and their nerve terminals will modify cholinergic transmission at these sites. Of course, the clinical usefulness of such agent is limited by diversity of their effects. I'm going to give you examples of some useful and unuseful drugs. For each drug mentioned, you should know mechanism of action and the changes in the effector cell activity. Interaction of that drug with other pharmacological agent, therapeutic usage and the rationale behind that usage, and of course some side effect of the drug. This diagram shows events and site of drug action at cholinergic terminal. As it was mentioned, synthesis of acetylcholine is dependent on choline taken up by neurons. Hemicolinium blocks the choline uptake pump and thus produce delayed block of cholinergic transmission. There is a delay because piriform acetylcholine must be used up. Hemicolinium has no clinical application because it will affect all cholinergic neurons. In another word, it is not selective. Cholinergic vesicle accumulate acetylcholine by active carrier. Acetylcholine carrier is blocked by vesomicol. Thus, gradually transmitter store is depleted, and cholinergic transmission therefore is inhibited. However, due to diverse effect, this type of agents has no clinical application. Botulinum toxin is produced by bacteria Clostridium botulinum in tin food. Botulinum toxin prevents release of acetylcholine from all cholinergic axons. Death in botulinum poisoning results from respiratory paralysis. It can be only treated with antitoxin. Botulinum toxin contains several components. They are peptides that cleave off a specific protein involved in the exocytosis of acetylcholine. In summary, botulinum toxin binds to a specific component of cell membrane, prevent vesicle fusion with the neuronal membrane, and hence prevent acetylcholine release. Botulinum toxin is a potent neurotoxin and specifically acts to inhibit acetylcholine release. Diluted solution of botulinum toxin injected locally into the muscle is used to treat blepharospasm, a form of persistent and disabling eyelid spasm, as well as other types of local muscle spasm like hemifacial spasm. Local injection of botulinum toxin produces long-lasting block of synaptic function on skeletal muscle. Beauticians also use Botox for wrinkle. Injection of a small quantity of botulinum toxin into a specific overactive muscle causes localized muscle relaxation and a smooth overlying skin, and therefore reduce wrinkles. Botulinum toxic effect take about 2 weeks to fully develop and last 3 to 4 months. The cholineceptors are divided into nicotinic and muscarinic subtypes. Cholineceptors of ganglia and skeletal muscle were designated nicotinic, since nicotine, a chemical substance found in tobacco, could readily mimic the action of acetylcholine at these sites. Nicotine at concentration which activate cholineceptor at neuromuscular junction and ganglia has no effect on muscarinic receptors. On the other hand, cholineceptor on smooth muscle, cardiac muscle, and exocrine glands were originally designated as muscarinic, since muscarine could readily mimic action of acetylcholine at these sites. Muscarine, a chemical substance isolated from fungus Amanita muscaria, at concentration which activate muscarinic receptors, has no effect on nicotinic receptors. Gene cloning has revealed 5 distinct types of muscarinic receptors: M1, M2, M3, M4, and M5. They are different in the sequence of their amino acids. This slide shows the location of nicotinic and muscarinic cholineceptor we are going to discuss from now on. Cholineceptors on skeletal muscle are nicotinic. The cholineceptors of autonomic ganglia, both sympathetic and parasympathetic, are nicotinic. The cholineceptor on adrenal medulla are also nicotinic. The cholineceptor on the target organ, innervated by post-ganglionic parasympathetic neurons, are muscarinic. The cholineceptor on sweat glands are also muscarinic. Remember, this is one of the sympathetic exceptions. We start with pharmacology of nicotinic cholineceptors of skeletal muscle. Skeletal muscle are innervated by alpha motor neuron. Each muscle cell forms only one contact with a branch of motor neurons. Here, the muscle cell membrane is specialized to form the motor end plate. Majority of mammalian skeletal muscle cells exhibit threshold behavior. That is, if the end plate is depolarized enough, an action potential is triggered. Example of agonist at nicotinic receptor on neuromuscular junction include acetylcholine, the natural neurotransmitter, nicotine, which is more potent than acetylcholine at neuromuscular junction, and a drug called succinylcholine. These agonists activate nicotinic cholineceptor at neuromuscular junction and evoke cell depolarization. Acetylcholine and nicotine have no clinical application. Succinylcholine is used as muscle relaxant, and I am going to explain how. This diagram shows nicotinic cholineceptor. Nicotinic receptors are directly coupled to sodium channel. As you see in this diagram, nicotinic receptors are situated on alpha subunits of receptor complex. Binding of acetylcholine to the nicotinic receptors will activate sodium channels. Influx of sodium ions depolarizes the muscle cell membrane. This diagram shows the normal events during neuromuscular transmission in fast-twitch fiber. Arrival of action potential in the nerve terminal release acetylcholine into junctional cleft. Activation of the nicotinic receptor induce an action potential in the cell membrane, which is propagated through the T-tubal system, and consequently release of calcium ion from sarcoplasmic reticulum. Release of calcium causes shortening of myofibril and therefore development of tension. Action potential firing allows the cell to develop tension quickly. Please notice, in fast twitch fiber, contraction is dependent on induction of action potential at neuromuscular junction. Without firing of action potential, there would be no contraction because calcium won't be released. Calcium in the skeletal muscle is only released from sarcoplasmic reticulum. In this figure, a structure of acetylcholine and succinylcholine is compared. The point I would like to make is that succinylcholine is composed of two molecules of acetylcholine. Two molecules of acetylcholine are attached together at this point. What is the difference between acetylcholine and succinylcholine? First of all, succinylcholine is a selective agonist at nicotinic receptor in neuromuscular junction. Unlike acetylcholine, that it has no effect on succinylcholine has no effect on ganglia or muscarinic receptor. Secondly, succinylcholine no longer hydrolyzes by the synaptic enzyme acetylcholinesterase, and therefore it has longer duration of action in comparison with acetylcholine. This figure is a record of action potential in a fast-twitch muscle cell. A stimulation of motor neurons depolarizes the motor end plate. When end plate potential crosses through the threshold of excitability, an action potential is produced, which propagates over the cell membrane. Each nerve stimulation only produces single action potential because acetylcholine is rapidly hydrolyzed by acetylcholinesterase. Succinylcholine activates nicotinic receptors and evoke depolarization. If this depolarization is sufficiently intense to cross the threshold of excitability, the muscle cell generates an action potential, as you can see here, and contracts. Since succinylcholine is not hydrolyzed by acetylcholinesterase, the muscle cell often generates several action potential and then enter a state where its membrane potential is less inside negative than threshold of excitability. Under such circumstances, the muscle cell becomes refractory to the stimulation of nerve supply. This is the stage of depolarizing blockade of neuromuscular transmission. Blockade persists until such a time as the end plate has repolarized to normal level. Therefore, injection of succinylcholine will initially produce twitches of individual fiber called fasciculation. This is due to the early phase of action potential firing. Then a phase of flaccid paralysis develops due to depolarizing blockade. That's why succinylcholine is known as depolarizing muscle relaxant. In summary, succinylcholine is used as muscle relaxant in surgical or temporary procedure to produce brief period of muscle relaxation. Succinylcholine induced muscle relaxant is short-lived due to hydrolysis by plasma cholinesterase. Succinylcholine is another generic name for succinylcholine, especially used in England. Although succinylcholine is used for short period of time, however, unwanted effects exist. The most important one is apnea. Therefore, there is a need to ventilate the lung. Malignant hyperthermia occurs in susceptible patients, especially when used with inhalational anesthetic such as Halothane. Hyperkalemic is due to release of potassium ions from muscles. It is not significant in normal individuals, but in patients with trauma, especially burns and injuries causing muscle denervation. Some patients complain about muscle pain after receiving succinylcholine. The cause is not well known, but there is an explanation. As you know, intense muscle contraction activate spindle muscle cells, which activate the stretch reflex arc. As it was explained, the majority of mammalian skeletal muscle are fast twitch fibers. However, the intrafusal fibers of the muscle spindle are exceptionally slow twitch type. Succinylcholine evokes a slow graded contraction of slow muscle cells. Successive stimulation has additive effect on tension development. That's why intravenous injection of succinylcholine into birds or amphibian evokes spastic paralysis, because they contain high proportion of slow cells. Therefore, as spindle muscle stays in contracted state, this phenomenon probably accounts for the soreness of muscle reported by patients after paralyzed with succinylcholine. Pharmacology of agonist at cholineceptor of autonomic ganglia. Nicotinic cholineceptor of ganglia are located all over the whole cell bodies of sympathetic and parasympathetic ganglia. Arrival of action potential to the nerve terminal of the presynaptic neuron result in acetylcholine release by calcium-mediated exocytosis into the synaptic cleft. It is only 20 nanometer wide. Acetylcholine diffuses toward the ganglion cell body and interacts with nicotinic receptors. As with nicotinic receptor on neuromuscular junction, the nicotinic receptor of ganglia are associated with ligand-gated sodium channels, acetylcholine being the natural ligand. Influx of sodium ions into ganglion cell body produce a rapid depolarization, which normally initiate an action potential. Action potential moves down the postganglionic axon. The released acetylcholine is hydrolyzed within 1 millisecond by acetylcholinesterase. So a presynaptic action potential produces only one postsynaptic action potential. Acetylcholine, nicotine, and a drug called carbachol activate nicotinic receptor of ganglia and evoke cell depolarization. They trigger a burst of action potential discharge by ganglion cell body. Therefore, agonists at the cholineceptor of ganglia exert indirect sympathetic and parasympathetic effect on smooth muscle, cardiac muscle, and exocrine glands. Ganglion stimulation may be followed by depolarization block, since these drugs, except acetylcholine, are not readily inactivated by acetylcholinesterase. Nicotinic agonists at ganglia stimulate both sympathetic and parasympathetic ganglia. So their effects are complex, including tachycardia, increase in blood pressure, variable effects on gastrointestinal motility and secretion, increased bronchial, salivary, and sweat gland secretions, and many other diverse effects. For this and other reasons, none of these agents are used clinically for their action on ganglionic cell bodies. Pharmacology of cholineceptors of smooth muscles, cardiac muscle, and exocrine gland. Cholineceptors were designated as muscarinic since muscarine could readily mimic the action of acetylcholine at these sites. Muscarinic receptors are activated by post-ganglionic cholinergic neuron. Most of these neurons belong to parasympathetic nervous system, but there are two exceptions, which are sympathetic. Those supplying the sweat glands and those providing a vasodilator pathway to the arterioles of skeletal muscle. Muscarinic receptors are located over the entire surface of effector cells. They are also found on cells that do not receive. They also found on the cells that do not receive a cholinergic innervation, for example, ventricular myocardium and the isthmus muscle of most blood vessels. Transmission mediated by muscarinic receptor is much slower in its time course. In some cases, acetylcholine functions as a modulator rather than as a direct transmitter. Important muscarinic agonists include acetylcholine, muscarine, carbachol, methacholine, bethanochol, and pilocarpine. They vary in muscarinic or nicotinic selectivity and in susceptibility to cholinesterols. This is the structure of acetylcholine. If this methyl group in here is replaced by an amine group, this compound is called carbachol. If a methyl group is added at this position, this compound is methacholine. If this methyl group is added at same position on carbachol, this synthetic compound is bethanochol. All these compounds are choline esters and will mimic action of acetylcholine, but with different degree of selectivity on muscarinic or nicotinic receptors. Notice the positive charge on the nitrogen atom means that these agents are not lipid soluble and have poor tissue penetration. In this table, properties of cholinesters on susceptibility to cholinesterols, muscarinic and nicotinic actions are compared. Acetylcholine is rapidly hydrolyzed by cholinesterols and therefore has very short duration of action. It equally activates both muscarinic and nicotinic receptors. Methacholine is still hydrolyzed by cholinesterols, but at a much lower rate. However, methacholine with little nicotinic activity has a relatively pronounced effect on the muscarinic receptors. Carbachol is resistant to hydrolyze by cholinesterols. Carbachol has adequate agonist activity at muscarinic receptor and may be used clinically because of this property. However, carbachol also has a powerful stimulant action on nicotinic receptor, which may result in ganglion stimulation and skeletal muscle contraction. Bethanochol is also resistant to hydrolyze by cholinesterols. It devoid nicotinic activity and used clinically for its action on the muscarinic receptor on the gut and bladder smooth muscle. Muscarinic receptors are G protein coupled receptors. They are membrane receptors that are coupled to intracellular effector system via a G protein. They also are known as 7 transmembrane spanning receptor. 1, 2, 3, 4, 5, 6, 7. There are several types of G proteins which interact with different receptor subtypes and control different effectors. For example, it may cause activation of phospholipase C, inhibition of adenyl cyclase, activation of potassium channel, or inhibition of calcium current. The type of G protein, enzyme, ion channel associated with the receptor determine the response to be excitatory or inhibitory in a specific tissue. For example, the muscarinic receptor on the sinoatrial node in the heart are M2 type and are associated with the potassium channel. When M2 receptors is stimulated, the G protein activates potassium channel on SA node. Outflow of potassium ion causes hyperpolarization and slows the heart rate. On the other hand, the muscarinic receptor on gastrointestinal tract are M1 or M3 subtype. These receptors are associated with phospholipase C via a specific G protein. Attachment of acetylcholine to the receptor increase activity of phospholipase C and therefore formation of intracellular messenger inositol 3-phosphate is increased. IP3 acts to increase calcium ions from intracellular store. Elevated ferric cytosolic calcium cause muscle contraction or gland secretion. Now I am going to describe effect of muscarinic agonist on the effector organ. Remember, the effect of muscarinic agonist is similar to parasympathetic nerve stimulation response. We start with muscarinic receptors of the eye. The ciliary muscle is a ring of smooth muscle. The lens is suspended at the center of the ring by means of ligaments. Acetylcholine evokes ciliary muscle contraction and the eye's accommodation is adjusted for near vision. The iris contains 2 layers of smooth muscles, circular and radial smooth muscle. The circular muscle receives only parasympathetic innervation, and acetylcholine cause contraction of circular muscle fiber. The pupil thus constrict. It causes meiosis. Agonists at muscarinic receptor also stimulate lacrimal gland secretion. The radial isthmus muscle of iris receives sympathetic innervation, and noradrenaline causes contraction of the muscle fiber, and therefore pharmacology of adrenoceptors applied to the radial muscle. This picture shows the anatomical location of ciliary muscle in relation to ligament. This is the ciliary muscle and this is ligament attached to the lens. Normally, the ciliary muscle is relaxed and the lens is relatively flat. Contraction of ciliary muscle pulls the ciliary body forward and inward. Relaxation of tension on the suspensory ligament of the lens allows the lens to bulge more and accommodate for near vision. Therefore, muscarinic agonist stimulation results in more convex lens and accommodation is adjusted for near vision. The heart receives both sympathetic and parasympathetic innervation. Acetylcholine acts on sinoatrial node, the pacemaker, and reduce the discharge rate of the node and heart rate falls. Therefore, muscarinic agonists will cause bradycardia or negative chronotropic effect. Parasympathetic neurons also innervate the atrioventricular node. Acetylcholine depresses conduction through the AV node and is associated Purkinje fibers. The ventricle myocardium does not receive parasympathetic innervation. However, muscarinic receptors exist on the ventricular myocardium. Administered muscarinic agonists could activate these receptors and decrease the force of ventricular contraction via release of EDRF. The isthmus muscle of blood vessels is arranged circularly around the lumen. Most blood vessels receive sympathetic innervation only. However, muscarinic receptors are found on the endothelium of blood vessels. Activation of muscarinic receptors by exogenous agonists would result in release of EDRF and vasodilatation. What is EDRF? EDRF is an abbreviation for endothelium derived relaxing factor. Exogenous acetylcholine act on muscarinic receptors on the endothelium layer to release EDRF. Nowadays, we know that EDRF is mainly nitric oxide, NO. Nitric oxide diffuses into the underlying muscular layer and activates guanylate cyclase, and therefore cyclic AMP production is increased. Increase in cyclic AMP level cause relaxation of smooth muscle. In the heart, cyclic AMP depress myocardial contractility. Muscarinic agonists contract respiratory smooth muscle and cause bronchoconstriction. Gland of the respiratory tract is also stimulated and bronchial gland secretion is increased. The propulsive muscle of gut receives both parasympathetic and sympathetic innervation. Under normal circumstances, the propulsive smooth muscle of gut is dominated by parasympathetic tone. Muscarinic agonists cause smooth muscle contraction and stimulate propulsive activity. Gastric and digestive gland of the alimentary canal is also stimulated. Generally, it can be said that muscarinic agonists increase exocrine gland secretions. The urinary bladder comprises a capsule of smooth muscle. The smooth muscle of the bladder comprises of the detrusor, the greater part of the capsule, and the trigone, that part bounded by the urethric orifice and the bladder neck. The detrusors receive parasympathetic innervation only. The released acetylcholine causes contraction of the detrusor, and therefore muscarinic agonists stimulate micturition. The trigone and bladder neck receive only sympathetic innervation. Arterioles of skeletal muscle receive noradrenergic sympathetic innervation. In addition, they receive a second sympathetic innervation. The postganglionic neuron in this pathway, however, is cholinergic and releases acetylcholine as a transmitter. Acetylcholine causes vasodilatation of skeletal muscle arterioles via muscarinic receptors. This vasodilator pathway is activated in response to emotional shock and so produce fainting, or in response to exercise. Eccrine sweat glands are also innervated by postsynaptic cholinergic sympathetic neurons, and muscarinic activation evoke sweat secretion. Remember, these two cases are exceptional cases of sympathetic nervous system that postganglionic neuron is cholinergic. Carbachol and bethanechol is used to stimulate the activity of smooth muscle of gut, bladder, and ureter. For example, to expel gas from the intestine prior to radiography or to reverse post-operative atony of the gut and bladder, and also to accelerate passage of ureteric stone. Bethanechol acts mainly on M3 muscarinic receptor and has little effect on the heart. Pilocarpine is a natural alkaloid and a muscarinic cholineceptor stimulant. Pilocarpine is a tertiary amine and exists in ionized and non-ionized form, and therefore penetrate readily. Pilocarpine eye drops are useful for lowering intraocular pressure in glaucoma. The circular muscle of iris is important in regulating the intraocular pressure. Aqueous humor is secreted by the cells of epithelium covering the ciliary body, and it drains into the channel of Schlemm. Paralysis of circular muscle of iris can lead to narrowing of angle between the base of the iris and the inner surface of cornea. This may predispose to impaired drainage of aqueous humor into the channel of Schlemm, and hence a rise in intraocular pressure. Therefore, pilocarpine is useful for lowering intraocular pressure in open-angle glaucoma and acute attacks of narrow-angle glaucoma. Long-term relief from attack may require surgery. Activity of ciliary body Activity of ciliary muscle also aids pumping of aqueous humor from channel of Schlemm into the veins. I would like to remind you that pilocarpine eye drop at the same time interfere with the eye accommodation, adjustment, and pupil is also constricted. Civimilin is a more selective M3 muscarinic receptor agonist. It is used in the treatment of dry eye and mouth associated with Sjogren's syndrome, a real autoimmune disease causing loss of parasympathetic function.